Hello everyone, this is Dr. Newsom, and we will be covering drug classes affecting the central nervous system and peripheral nervous system, Part 2. So here are our objectives for this particular presentation. We're going to be looking at the discussion of the mechanisms of action, indication for use, and major effects of selected drugs that affect the central nervous system and the peripheral nervous system. We're going to be looking at discussing the role of alternative and complementary therapies for condition of the CNS and PNS. We'll identify client-related factors that influence these drugs that affect the central and the central nervous system and the peripheral nervous system. We'll utilize our pharmacological resources and drug guides to make appropriate decisions regarding nursing interventions for these clients that are receiving these drugs that affect both the central nervous system and the peripheral nervous system. And then we're going to use the nursing process to determine the safe care for a client who is receiving medications that affect the central and the peripheral nervous system. Our focus today is going to be on drugs that are CNS depressants. Okay, so CNS depressants causes a varying degrees of depression or reduction in functional ability. It reduces our ability to complete our functional activities. Classifications of CNS depressants include sedative hypnotics, general anesthetics, analgesics, opioids and non-opioid analgesics, anticonvulsants, antipsychotics, and antidepressants. Today, this presentation will focus in on depressants, okay? Depressants and anesthetics. Let me just add that one there too. Start with insomnia. So insomnia is the inability to fall asleep or to remain asleep. It usually occurs in about 10 to 30% of Americans, and over 70 million Americans suffer from chronic sleep problems or sleep deprivation. Normal sleep actually has two phases: rapid eye movement, or REM, and non-rapid eye movement. There are different stages of sleep, but as you can tell from this figure here, that once one stage is disturbed, the process starts all the way back to stage 1. So let's take a closer look at insomnia. We know that insomnia is more common in female clients than male clients. Our normal treatment option typically for insomnia can be sedatives, hypnotics, and we're going to talk more about this as we move further in. So now, one of the things that we want to encourage our clients is before we give them medication, we want to look at non-pharmacological ways that we can actually manage insomnia or help our patients manage insomnia without the use of medication. When we give our patients medication, we have to worry about things like side effects. We have to worry about drug interactions, food interactions, things like this. And so one of the things that we want to try to do before the onset of medication is to offer ways or solutions to achieve sleep without medication. So let's take a look at some of these non-pharmacological sleep management techniques. One of the things we want them to do or encourage them to do is arise at specific hours in the morning. Try to get up the same time every morning. Limit those daytime naps. Either limit them or completely get rid of them, okay? Avoid caffeine, alcohol, nicotine, these things 6 hours before bedtime. Then also avoid things like heavy meals and heavy fluids at night, okay? So loud noise, strenuous activities, these are not necessarily good for our clients that have insomnia. Taking a warm bath, reading, listening to quiet music, drinking warm milk. These are all things that also can be used as a way to kind of depress the night away, to put them in peace and kind of move into the evening to help improve insomnia. As you see here, we can use sedatives to actually treat sleep disorders, or we can use a combo drug, sedative hypnotics. So sedative hypnotics tend to run in the way of barbiturates, benzodiazepines, and non-benzodiazepines. And we're going to talk a little bit more about each one of these here. Sedatives are mostly used during daytime and produce a hypnotic effect or a natural sleep state. Hypnotics may be short or intermediate acting. We use short term to prevent dependence and tolerance. Abruptly discontinuing a high dose of either a sedative or hypnotic or a sedative hypnotic can cause withdrawal symptoms. So what we want them to do is taper the dosage to avoid withdrawals. Patients with severe respiratory disorders should avoid hypnotics. Hypnotics should also be avoided during pregnancy. Sedative hypnotics actually has general side effects that include things like residual drowsiness, or they have that feeling in the morning of what we call a hangover. Many of these patients may exhibit vivid dreams or even nightmares. Some may develop drug dependence as well as drug tolerance. They have excessive depression, so we must follow these patients for suicidal ideation. Respiratory depression, and we're going to be talking a little bit more about respiratory depression again. There's sedation, but respiratory depression is a deeper level, meaning it reduces that respiratory rate and places that patient at high risk for death due to inability to sustain the body because of a decreased respiratory rate. And then some patients may exhibit hypersensitivity to these drugs. Take a look at our prototype drug, which is alprazolam. Now you see at the very end of that, alprazolam, L-A-M. All benzodiazepines end with L-A-M. This will be a helpful review term for you guys so that every time you see a drug that ends in LAM, you automatically know that this is a benzodiazepine. All of our benzodiazepines end in LAM. So remember that. As you see one drug, you're going to be seeing all benzodiazepines. They work the same, they have the same contraindications, and this will help you so that you don't have to remember a lot of medications, drug names. So let's discuss some benzodiazepines. We know that benzodiazepines are anti-anxiety agents used to decrease anxiety and induce sleep. They're used short-term for sedation and insomnia, and as our alprazolam here is used to treat anxiety and panic disorders. The mode of action is a CNS depressant. That's what it does. It binds receptors in the limbic system and reticular formation, increases our GABA and GABA receptors. It shifts the chloride ions, which leads to less excitability and stabilizes the neuronal membranes. So generally speaking, it causes CNS depression. Contraindications, again, because it depresses that CNS system, you don't want to give it to patients that are already in respiratory depression. They already have a slow CNS. Okay, you don't want to give it to those patients because it's only going to increase that depression. Patients that are acute alcohol intoxication, no, you don't want to give it to those patients as well. Psychotic reactions, again, we talked about that suicidal ideation. We don't want to give it to patients that have psychotic reactions. And recent respiratory depressants, okay? So if they're on respiratory depressants already, you're not going to give alprazolam to these clients. Again, use with caution, suicidal ideation, and drug abuse. Let's look at some of the side effects for prazolam. So we know again it's a CNS depressant. So we already know that some of the things that we're going to see with this drug is drowsiness, dizziness. Because our patients are drowsy, because they are dizzy, we may have to provide them with special education as to rising early, not driving while they're taking this medication. Additionally, these patients may experience amnesia. They do what we call sleepwalking. They do things that they don't remember doing, like raiding the refrigerator at night, maybe driving somewhere or doing odd behaviors in the middle of the night through sleepwalking, but they have no memory of it in the morning. And so we've got to be able to monitor these patients very closely for those types of actions, or even educate them on the potential side effects that may occur because of this. Memory impairment is also there. GI effects may also occur as well. And then some adverse effects, some things that are really bad. Depression. They may develop tolerance to the drug, so it doesn't work quite as well as it did before. They may become dependent on the drug. They may experience withdrawal. Again, that hypotension, that blood pressure drops, that heart rate goes up, tachycardia, and then they may also experience seizures as a result of this. Some life-threatening considerations that we need to remember are hepatic failure and then Stevens-Johnson syndrome. With prazolam, this drug will not be used for longer than 3 to 4 weeks. It is for short-term purposes only. So let's look at some of the assessments, diagnosis, and the planning, this nursing process that we're going to be looking at for our patient that is on prazolam. The assessments. Okay, we want to determine whether the client has a history of insomnia or anxiety disorders. Obtain that drug history. Remember, we've got to get a reconciliation of all their current drugs, including their over-the-counter medications, as well as their complementary medications as well. We need to know what's going on with that renal functioning before we start them on this medication. And you remember, with renal, that's kidney, what are you looking at? BUN, creatinine. Very good. Nursing diagnosis that we're going to be looking at. Sleep deprivation, of course, they're getting it for insomnia. Sleep deprivation related to adverse effects of insomnia. And what's our planning? What's our goal for these clients? The patient will receive adequate sleep when taking benzodiazepines. Very good. So let's take a look at some nursing interventions that we will encourage or use with our patient that is taking prazolam. We want to observe this client for adverse reactions, especially in our older and our debilitated client. Okay, you guys remember that, as a side note, that this drug is highly protein bound. When used with other drugs that are high protein bound, it may leave a lot of prazolam floating around in the system, which places these patients at higher risk for issues such as respiratory depression, toxicity. We want to teach our clients to use non-pharmacological methods to induce sleep, and we talked about this earlier. You want to use as many non-pharmacological measures as possible to help with sleep so that we can reduce the potentials of side effects. We can reduce the potentials of medication side effects that come along with the use of these drugs. We want to teach our clients not to drive or operate heavy machinery. We don't want these clients to combine them with complementary alternative medications that can also cause problems or cause increased depression in the system. We want to teach the client that benzodiazepines need to be slowly withdrawn. Remember, a quick withdrawal or quick discontinuation of the drug can result in withdrawal. Okay, so we do not want this. The other thing that we want to ensure with our client is that they know about the antidote. So if they experience benzotoxicity, or if they experience respiratory depression, because you remember that's one of the main things that we're dealing with here is patients move into a respiratory depressed state. They have trouble breathing. You're going to administer flumazenil. Again, this will help with benzotoxicity and it will reverse the effects of sedation with these clients. One of the problems that you have to look for with flumazenil is also respiratory depression. So we've got to be particularly vigilant with our clients that are on or that we have given flumazenil to. Remember, prazolam is a temporary fix, no longer than 3 to 4 weeks for insomnia. Looking at that, considering that, again, we must look at those complementary and alternative therapies that patients may use for insomnia, but it's not good to be used with a prazolam. Those things are, again, we talked about kava kava. It should not be used with any CNS depressants, any, because it's going to increase the effects as well as valerian. It will also decrease sedative effects. So we've got a patient that we're looking at things like we're worried about respiratory depression. This is going to only increase the risk for that. Chamomile, used to treat sleepiness, anxiety, and stomach or intestinal ailments. So they may not even be looking to use chamomile for sleep. They may be looking to use it because they want it for upset stomach. But when they combine it with one of the CNS depressants, it will also increase the sedative effects. Here we have another sedative hypnotic used for insomnia. However, it is a non-benzodiazepine. That means it is not a benzodiazepine. It is zolpidem tartrate or Ambien. It is used for short-term treatment, usually less than 10 days. It has a short half-life of 1.4 to 8.4 hours, and we decrease our dosage usually for our older adults, and we'll talk about that here again in just a few minutes. The mechanism of action, it is a CNS depressant, so it causes CNS depression, neurotransmitter inhibition. That's how it works. It is contraindicated for patients that have a high hypersensitivity to benzodiazepines. So if they don't do well with benzos, this is not the drug for them. Again, remember it is a CNS depressant, so you will not give this medication for patients that are in respiratory depression because you will continue to create a more depressed state. We will kill them. Patients that are lactating, this is not really the drug for them. It will be used in caution for patients that have renal or liver dysfunction. Those patients that have mental depression or suicidal ideation. And again, pregnancy. This is not the drug to use for pregnant women. Children, we cannot necessarily give children the same medications as adults. This is one of those drugs that have to be used specifically in caution with children and our older adult populations. Again, I told you earlier that this is going to be one of those drugs that we will decrease that dosage for our older adult population. And then we need to watch carefully in our debilitated individuals as well. Zolpidem, we know, again, is a non-benzodiazepine, but it has some of those same effects, some same side effects. You see, hangover. They may have some residual sedation from the use of the medication, and patients may feel like they're hungover in the morning. Memory impairment, nightmares, binge eating. You see some of these same side effects that we saw with our prazolam, our benzo. And then, of course, some adverse effects, tolerance, They may develop a tolerance for the medication, psychological or physical dependence, and even withdrawal effects. Sleep-related behaviors, similar to what we saw with our benzos, hypotension, drop in blood pressure, angioedema, that swelling in the throat that blocks off the airway, swelling in the mouth, angioedema, depression and suicidal ideation as well. And then some life-threatening issues that we have to watch for with these clients is pulmonary edema, that's fluid buildup in the lungs, and then renal failure, kidneys fail. Let's look at zolpidem as we examine it through the nursing process. Our assessments. We need to gather a baseline vital signs and lab test, especially our liver enzymes. You remember the liver enzymes? What are you remember? They're all the A's, ALT, AST. All of those A's are our liver enzymes. We want to get a drug history for this particular client. We've got to know what other medications are they taking. So we want to do a drug reconciliation along with our over-the-counter anti-CAMs that they're taking. Determine, if possible, the client's problem with sleep disturbance. We want to determine what actually is going on with this particular client. Because again, if we can fix this using non-pharmacological measures, we're going to try that first. What are some nursing diagnoses that we're going to look at? Of course, sleep deprivation, right? Fatigue related to insomnia. Patients that don't get through that whole full stage of sleep, they have a lot of fatigue in the morning. It prevents them from really being able to function properly throughout the day. What are some of our goals for these clients? Think about it. Patient will remain asleep for 4 to 6 hours, or 6 to 8, 6 to 8 hours, because we want them to get at least 6 to 8 hours of sleep a night. And then some of the interventions that we're going to be looking at doing for these clients, we want to be able to monitor those vital signs, specifically those respiratory related vital signs, respiratory rate, blood pressure, oxygen status, lung status. These are things that are going to help us determine if this patient is in respiratory depression. And then for patients that are taking this drug for the first time, we may have to put a bed alarm in for these clients, especially our elderly clients, because it may make them a little loopy. They may climb out the bed. They may be a little off. And again, we talked about those hangovers that they experience. And so our elderly clients are really going to feel that. So what are we going to include in our client teaching for a patient that is on zolpidem? First of all, you remember, we want as much as possible, we've got to discuss those non-pharmacological methods. We want them to try these first. Then, for those patients that are on zolpidem, or the doctor has deemed it necessary for us to put them on this particular drug, we want to encourage them. Avoid alcohol, any antidepressants, any antipsychotics or narcotics, or any type of drug that's going to depress the CNS, depress the peripheral nervous system. We want them to avoid those particular medications while they're using this drug. And you remember, zolpidem is for short-term use only. For the most part, 10 days at the most. And I think your book even discusses the fact that it's not necessarily meant to be used every day for 10 days. It's going to be used for a few days, come off of it, go back on it for a few days, but not in succinct, okay? So it's not to be used more than 10 days in a row. This is a short-term use medication. So the other piece of the puzzle that we've got to remember to encourage our patients is this drug needs to be taken just before bed. The effects take effect really quickly, 15 to 30 minutes, and it's working. So you don't want them driving or, out, sightseeing or whatever. You want them to take this medication just before you go to bed because you remember we talked about that short half-life on it. And so you want them to really be prepared to go to bed. Okay, again, no driving because it can cause drowsiness. It's going to suppress the CNS. Let's consider sedatives and hypnotics for older adults. We've looked at some of our concerns with both our benzodiazepines and our non-benzodiazepines, but let's look at it closer. Again, we want to try to determine the reasons for insomnia because we want to use, if possible, non-pharmacological methods first before we utilize any of our sedative and hypnotics. If we have to use them, we want to use short to intermediate acting. None of that long acting stuff. When it comes to our older adult populations, we have to have short to intermediate acting for these patients. Avoid those long acting. Use 4 times a week or less to avoid those side effects. And again, we talked a little bit about this for both our drugs, our non-benzos and our benzodiazepines. Now let's take a quick look at anesthetics. So we know that there are 2 types of anesthetics. We have general anesthetics and we have local anesthetics. So our general anesthetics depresses the CNS system. It alleviates pain and it causes a loss of consciousness. So purposely, we're giving patients a drug or drugs, a combination of medications that can depress that CNS system, help get rid of pain, and actually cause them to go to sleep. It causes a loss of consciousness. The reason why I'm emphasizing this is because there's going to be certain things that we as a nurse have to monitor these clients for when we purposely put them to sleep for the purpose of pain or for the purpose of depressing the CNS system, whichever case it may be. We're going to be looking at a little bit of that here in just a few minutes. Our local anesthetic, we know, causes pain relief in a limited specific area, and we're going to talk about that here again as well. Anesthetics can be given in a number of different routes. It can be given by inhalation, it can be given by IV, can be given by topical, local, or even spinal. So we've got different ways that we can actually give our anesthetics. We know that some of the quickest ways to get it in our patients is probably going to be IV. And so with IV anesthetics, we've got to be particularly careful with respiratory depression with these particular clients. Take a look at topical anesthetics. We know that topical anesthetics, its use is limited to the mucous membranes, broken or unbroken skin surfaces, and burns. So we can apply a topical solution to these areas for pain relief. So the forms may come in a solution. It may be a liquid spray, ointment, cream, gel, or powder. It decreases the sensitivity of nerve endings of the affected area. So that's what it does. With our local anesthetics, we know that our local anesthetics block pain at the site where the drug is given. It prevents nerve impulses. That's how it improves or blocks the pain. With our local anesthetics, consciousness is maintained. So this again is very different from our patients that receive general anesthesia where we knock them completely out. We knock the entire body out. Everything is out. Okay. So with local anesthetics, that is not the case. It is localized to a certain area. We use this for dental procedures, short-term or minor surgeries at a localized area. We even use it for blocking nerve impulses, like a nerve block below the insertion of a spinal anesthetic. So spinal anesthesia is a local anesthetic. Diagnostic procedures such as lumbar puncture and thoracentesis. So we use that for that as well as regional blocks as well. So we've got a lot of reasons why we would use our local anesthetics. So let's look at anesthetics and the nursing process. We're going to pay specific attention to both our general anesthetics and our local anesthetics. First of all, we know that we're going to get an assessment. We've got to obtain a drug and a health history, looking at those drugs particularly that affects the cardiopulmonary system, so the heart and lung system, okay? So why do we need that? We need that particularly for our patients that are going to be receiving general anesthesia, because we're giving them medications that are going to purposely knock them out. It's going to purposely slow down all of their systems, the CNS, the PNS. It's going to slow down everything, right? But body doesn't know that it's going to do more than that. It just knows that that's what it's supposed to do. So beforehand, we need to know exactly what we're dealing with. We need to know all the drugs that this patient takes, those particularly that affect the CNS, those particularly that affect the heart and the lungs. And then we need to know a good health history on this client. We need to know what's going on with the patient, what has gone on with the patient. We're going to be looking at nursing diagnosis of pain, of course, whether it's a local or general. And then we're going to be looking at breathing pattern. Again, remember with that general anesthesia, we are knocking them completely out. The patient loses consciousness with this process. Okay, so this is going to be very important for us to monitor that breathing pattern, specifically for these type patients or patients that have received general anesthesia. We want to know that it has not overworked itself or done a better job than what we could have expected it to do. So we've got to monitor that breathing pattern for these patients to ensure that they do not go into a respiratory depression state. Again, what type of goals are we going to be looking to have for these clients? The patient will participate in pre-op preparation and will understand postoperative care. So now here we're looking at postoperative care. When does discharge teaching actually begin? If you guys remember, discharge teaching actually begins preoperatively. It happens before they go into surgery. We will start teaching these clients what's going to happen during the process, before, during, and after the process. And then we're going to tell them what's going to happen to them when they go home. So we start that postoperative teaching preoperatively. And so this is going to be one of our goals. We're going to combine all of these into one of our goals so that the patient will understand exactly what's going to happen pre-op, during the surgery, and postoperatively. So let's consider the nursing interventions that we need to take for the patient that has received some sort of anesthetic, whether it's general anesthesia or whether it is local anesthesia. We know that we're going to monitor the postoperative state of sensorium. So we've got to be able to monitor these patients afterwards for their LOC. We've got to be able to monitor them for what they're feeling after the procedure. Our main concern is, again, for those patients that have had general anesthesia, we've got to really be able to determine their state of sensorium afterwards, after this process. We want to observe preoperative and postoperative urine output. We want to look at what our baseline was and determine if there are any complications after surgery. A drop in urine output after surgery may indicate potential complications. We want to monitor vital signs following the general and local anesthesia for a drop in blood pressure, and then a potential risk for respiratory depression. So we're monitoring these clients for respiratory depression. Again, that's going to be specifically for our patient that has had general anesthesia. Administer an analgesic with caution until the client fully recovers from the anesthetic. So when they have already been given and an anesthetic, we want to really be careful how we give other analgesics on top of that. We want to make sure that they have kind of that medication have worn off before we give them something else. So that's going to be one of those things that we're going to have to monitor or do for these clients. And then we want to be able to look at the whole entire process and said, the goals that we set, did we meet those goals? Do we need to change up something? You know, you want to be able to evaluate whether it worked or not. And I'm glad to say that's the end of our presentation for today.